Good morning, everyone. Thanks for joining us for this session of Asthma Grand Rounds, the beginning of the year. Happy New Year to everybody. Hoping that this is a good, joyful, and productive year for everyone. And today we're excited to have Melody Duvall, who's from the Division of Critical Care Medicine at Boston Children's Hospital, speaking to us. She's going to be speaking about type 2 low asthma. What do we know? What do we need to discover? Melody is a physician scientist trained in immunology and pediatric critical care medicine. She's an attending physician in the pediatric ICU at Boston Children's Hospital next door, and a physician investigator at the Brigham Women's Hospital in the Pulmonary Division's Airway Inflammation Resolution Laboratory with Bruce Levy. Her translational research is focused on innate immune pathways and diseases of lung inflammation. In particular, she's interested in RSV infection and severe asthma, with a focus on cellular and molecular pathways for the resolution of lung inflammation. Research has been funded by NIH K-12 and K-08 awards, and most recently, we're proud to announce that she got her first R01, and she's a co-investigator in the NHLBI Severe Asthma Research Program. Today, Melody is going to share insights in type 2 low inflammatory pathways in asthma. What do we know? What do we need to discover? And just a few housekeeping pieces for the live webcasting audience. You can submit a question to our speaker by entering it into the chat. For CME credit, and email your name and address to eIsrael Assistant, eIsrael EISRASST at bwh.harvard.edu. It'll also work if you do it at eIsraelasst@partners.org, if that's a little shorter for you. If there are any technical problems during the live broadcast, please send an email to BWH Webcast Troubleshooting, BWH Webcast Troubleshooting at partners.org. That's a mouthful. And again, we really welcome Melody and thank you for sharing your time and your expertise with us on type 2 low asthma. What do we know? What do we need to discover? And Melody, I'll turn it over to you.
Thanks very much, Elliot, for the kind introduction, and to you and Dr. Fanta for the invitation to speak today to the broader MGB asthma community. Just want to make sure those slides look correct to you.
They do.
Great. So today I'm delighted to review what we know about type 2 low inflammation in asthma, what we're beginning to discover, and what's on the horizon for potential new therapies. What we've known for many years are the hallmark histopathologic characteristics of severe asthma. Here, in contrast to a normal healthy airway, the severe asthma airway is characterized by significant pathologic changes: goblet cell hyperplasia, smooth muscle hypertrophy, subepithelial fibrosis, and increases in some mucosal blood vessel and gland volume, as well as inflammation. These conspire to lead to the airflow obstruction and bronchial hyperresponsiveness that result in chronic symptoms of wheeze and shortness of breath in asthma. But here at the level of histology, our window into airway inflammation in asthma is blunt. And the lingering question of what type of inflammation is present persists. What has been discovered about airway inflammation in asthma over the past decades is quite a lot. Many pathways contributing to type 2 inflammation have been uncovered here in the left part of this illustration. Eosinophils, mast cells, TSLP, Th2 CD4 T cells, and ILC2s producing type 2 cytokines, IgE producing B cells. And incredibly, there are now 6 FDA-approved biologic therapies targeting type 2 inflammatory pathways for severe uncontrolled asthma. But what we have much more left to discover in this smaller part of the illustration is about type 2 low inflammation pathways. So my objective for today is to highlight what we're beginning to understand about type 2 low inflammation pathways, including neutrophils and neutrophil extracellular traps or netosis, Th17 and Th1 CD4 T cells, natural killer cells, my particular area of investigation, disrupted inflammation resolution pathways, mast cell biology, and IL-6 and metabolic dysfunction. And interspersed throughout, I'll highlight therapies that have come through the pipeline or are on the horizon for treating T2 low asthma. Type 2 asthma is characterized by eosinophilic airway inflammation and elevations in levels of fractional exhaled nitric oxide, FeNO, and IgE that can generally be suppressed by glucocorticoid steroids and now biologic therapies targeting type 2 inflammation. Type 2 low asthma patients generally do not have evidence of T2 inflammation with low sputum and blood eosinophils and FeNO. But this disease subgroup is heterogeneous and lacks defining biomarkers. Inflammation is generally neutrophilic or polygranulocytic, and patients are generally older, more likely to be obese with metabolic dysfunction, and importantly, are often steroid resistant, identifying an unmet need for new therapies targeting pathways other than type 2 inflammation for this group of asthma patients. Neutrophilic inflammation has been associated with lower lung function in asthma. On the left, in this study out of the UK 20 years ago, induced sputum neutrophil counts on the x-axis were inversely associated with FEV1% predicted. Similarly, from Prescott Woodruff and John Fahey at UCSF, sputum neutrophils, comprising about 40% of sputum cells, were inversely correlated with FEV1, but not PC20. These data suggest that neutrophils may be involved in the pathophysiology of airway obstruction in asthma, but perhaps not as correlated with bronchial hyperreactivity. More recently, transcriptomics analysis has revealed distinct gene signatures associated with neutrophilic asthma. Peter Wark's group in Australia examined endobronchial biopsy samples in patients with severe asthma characterized as either neutrophilic, here in A, or eosinophilic or polygranulocytic. Interestingly, the neutrophilic group was most distinct, with a gene signature enriched in pathways previously linked to neutrophilic inflammation, including Th1, the inflammasome, and Th17. And I'll highlight here that the highest upregulated gene in the neutrophilic asthma group was serum amyloid A, an acute phase protein that activates the inflammasome and promotes neutrophilia. I'll come back to SAA later in some of our own work in severe asthma. Finally, of interest in this study was the finding that bacterial colonization was more common in the neutrophilic group of asthma patients. So what's come through the pipeline thus far for targeting neutrophilic inflammation in asthma? While not directly targeting neutrophils, macrolide antibiotics have well-known antibacterial and anti-inflammatory effects. And in the AMAZES study led by Peter Gibson, azithromycin was examined in a randomized, double-blind, placebo-controlled trial of 420 adults with moderate to severe asthma over the course of 48 weeks. Azithromycin in the blue was effective at reducing asthma exacerbations and asthma-related quality of life measures, and improved the rate of being exacerbation-free at a year from 44% to 61% in the azithromycin arm. Notably, in subgroup analysis, azithromycin was effective at reducing exacerbations in both eosinophilic and non-eosinophilic asthma subgroups, suggesting that azithromycin may not just be addressing bacterial colonization, but perhaps has additional immune effects. The results of this study and subsequent meta-analyses have led to the recommendation for the option for add-on azithromycin to ICS plus LABA for patients with difficult to control asthma. There have been a number of clinical trials targeting pathways relevant to neutrophilic inflammation in asthma, but unfortunately none have demonstrated clear benefit, and some were associated with adverse events. TNF-alpha, produced by multiple cell types, including Th1 CD4 T cells, promotes neutrophilic inflammation, but clinical trials of anti-TNF antibodies failed to show benefit and were associated with serious infections. IL-8 is a major neutrophil chemoattractant secreted by epithelial and immune cells and engages CXCRs on neutrophils. Unfortunately, several studies of CXCR2 antagonism did not reduce exacerbations or substantially improve asthma control. IL-17, secreted by Th17 and group 3 ILCs, also promotes neutrophilic inflammation, but a trial utilizing an IL-17 receptor blocker did not improve asthma control. And most recently, the anti-IL-23 antibody risankizumab, which blocks Th17 cell differentiation, was also found not beneficial for asthma control. Now, notably, these trials did not select subjects on the basis of neutrophilic inflammation or increased specific cytokine levels. But what they really underscore is that a better understanding of pathways contributing to type 2 low neutrophilic inflammation in asthma is needed. I'd like to highlight some of our work in the Severe Asthma Research Program focused on improving this understanding of cellular, molecular, and biologic mechanisms underlying non-type 2 inflammation pathways. As this audience is aware, the SARP network is a comprehensive, longitudinal, multi-center study of patients with severe asthma that's been funded by NHLBI for nearly 20 years now. And at its peak, the SARP cohort includes 700 participants from 7 leading US asthma clinical research centers across the country, including Brigham and Women's Hospital and Boston Children's Hospital locally. In SARP-3, 120 asthma subjects agreed to undergo bronchoscopy at their symptomatic baseline, and we collected BAL fluid and cells for study in the laboratory. And today, I'll share data from 3 of our published studies, in fact, in SARP-3, in which we performed flow cytometry cellular analysis in 53 asthma subjects and 21 healthy control subjects. What was notable about this cohort, even just looking at BAL cell counts and leukocyte differentials, was that the severe asthma cohort had increased neutrophils compared to the non-severe asthma and healthy individuals. 2 to 3-fold more neutrophils in the severe asthma group relative to the other subjects. What we were also interested in examining here with flow cytometry was the lymphocytes in BAL. Lymphocytes comprise 6 to 7% of BAL cells, and we aimed to examine relationships between lymphocyte subsets and neutrophils in the asthmatic airway. I've been particularly interested in natural killer cells for the past few years because these innate lymphocytes are important in host defense, in particular viral infections, a major driver of asthma exacerbations. But NK cells also contribute significantly to the resolution of inflammation by inducing apoptosis of inflammatory leukocytes. Leukocytes in circulation, such as neutrophils and eosinophils depicted here, are recruited to lung sites of inflammation or infection and become activated. NK cells recognize abnormal or exhausted leukocytes and induce apoptosis for subsequent macrophage phagocytosis to aid in restoring tissue homeostasis. So a circulating NK cell shown here in contact with an autologous neutrophil and an eosinophil ex vivo triggers cell death. And both of these cells show nuclear condensation and cell shrinkage consistent with apoptosis. Cindy Barnig, working with Bruce Levy in the SARP cohort, found that peripheral blood NK cells from severe asthma patients were impaired in their ability to induce autologous granulocyte apoptosis relative to patients with mild asthma and healthy controls. Now, this study was focused on peripheral blood, circulating blood NK cells. And in our study, we aimed to identify NK cells in BAL. So here we used flow cytometry to identify NK cells in BAL as lymphocytes that were CD3 negative, NKp46 positive. And relative to healthy control subjects in gray, both non-severe asthma subjects in tan and severe asthma subjects in red had a significantly decreased percentage of BAL NK cells by approximately half. And as a reminder, severe asthma subjects had increased BAL neutrophils. And when we looked at the ratio of neutrophils to NK cells in BAL, that ratio was dramatically increased in severe asthma. Further, the number of cytotoxic or CD56 dim NK cells in BAL was inversely correlated with FEV1% predicted, identifying a relationship between cytotoxic NK cells in BAL and worse lung function in asthma. We also examined T cells in BAL and found that CD4 T cells were increased in severe asthma patients. Here we used expression of chemokine receptors, CCR4 and CCR6, to define subclasses of CD4s and found that both Th1 and Th17 CD4 T cells were increased in severe asthma, but numbers of Th2 enriched CD4s was not different. The ratio of Th1 to NK cells in severe asthma was nearly 3 times that in health. The ratio of Th17 to CD4s was similarly increased in severe asthma. And notably, we identified an inverse relationship between the number of Th1 CD4 T cells and FEV1% predicted, suggesting an important relationship between Th1 inflammation and lower lung function in asthma. So together, these findings identify that severe asthma is distinguished by a relative paucity of BAL NK cells relative to leukocyte effectors of non-type 2 airway inflammation, in particular neutrophils and Th1 and Th17 CD4 T cells. This finding of type 1 and type 17 inflammatory cells in some severe asthma patients was also evident in this study by the Ray group at Pittsburgh. Here, in a subset of SARP3 patients, CD4 T cells producing interferon gamma or IL-17 were more frequent in severe asthma patients in the closed circles relative to those with mild to moderate asthma in the open circles. And BAL interferon gamma levels, but not IL-17 levels, were higher in the severe asthma cohort. In a follow-on study, this group identified that CXCL10, a chemoattractant for Th1 cells, was increased in severe asthma, and that CXCL10 correlated with interferon gamma mRNA in BAL and asthma. So these studies shed light on novel mechanisms of a Th1 non-type 2 inflammation pathway operative in severe asthma. Honing in now on the Th17 pathways, we recently published that neutrophil cytoplasts could induce Th17 differentiation and skew inflammation to neutrophilia in severe asthma. In response to inflammatory stimuli, neutrophils undergo netosis, releasing DNA containing extracellular traps or nets, and leaving behind enucleated cell bodies called cytoplasts. The ejected double-stranded DNA can interact with dendritic cells via TLR2 receptors to promote the generation of Th2 CD4 T cells. And in this study, led by Nandini Krishnamurthy and our group, using a preclinical model of allergic lung inflammation, we identified that cytoplasts could influence dendritic cells to evoke allergen-driven Th17 cells and non-type 2 inflammation with neutrophilia. In this study, we also examined BAL fluid from SARP3 subjects and detected nets using CYTH3 by Western blot, in particular in severe asthma subjects with high neutrophil counts. Notably, BAL fluid levels of cell-free DNA in severe asthma was strongly correlated with BAL neutrophil count. John Fahi's group at UCSF demonstrated that netosis could be detected also in sputum using CYTH3, and that sputum neutrophil percentage correlated also with cell-free DNA in these SARP subjects' sputum. We went on to identify neutrophil cytoplasts using flow cytometry and found strong correlation between BAL IL-17 levels and the number of neutrophils and cytoplasts in BAL and asthma. So together, these translational findings identify lung netosis in asthma patients with neutrophilic predominant inflammation and identify an association between cytoplasts and IL-17, suggesting that cytoplasts can skew an adaptive immune response towards Th17 to propagate lung neutrophilia. In SARP-3, we also measured BAL levels of a number of mediators, including the acute phase reactant serum amyloid A I mentioned earlier, as well as the pro-resolving mediator lipoxin A4. In this study, we evaluated relationships between BAL, SAA, and LXA4 levels with asthma symptoms and lung function in a Pearson correlation matrix, here including data from 120 asthma subjects. And what we found here is that LXA4 and SAA levels were inversely correlated with one another. LXA4 levels were positively correlated with measures of lung function, so higher FEV1 and FVC, and were associated with better asthma symptom scores. In contrast, LXA4 was inversely correlated with BAL neutrophils. Here, serum amyloid A levels alone did not correlate with asthma symptoms or lung function, but was highly correlated with BAL neutrophils. So here I'm focusing on an acute inflammatory protein, SAA, and a pro-resolving lipid mediator, lipoxin A4. What's been discovered over the past several decades is that the process of acute inflammation resolution is an active one. And this process is orchestrated in large part by a superfamily of mediators coined specialized pro-resolving mediators, or SPMs. These SPMs are enzymatically derived from essential dietary polyunsaturated fatty acids into discrete families with now over 30 distinct described mediators, including the first SPM discovered and characterized, lipoxin A4. SPMs are quite unique because they have both anti-inflammatory and pro-resolving properties. So they not only work to block inflammatory mediators and stop neutrophil recruitment, they also stimulate pathways for tissue repair. In the early days of SARP, the first novel finding in this area of lipid mediator biology, led by Bruce Levy, was that levels of pro-resolving mediators were different in asthma. Here, whole blood was stimulated ex vivo, and the biosynthetic capacity for LXA4 production was severely impaired in severe asthma. Follow-on studies demonstrated that levels of airway LXA4 were much lower in severe asthma relative to non-severe asthma and health. We now understand that SPMs signal through distinct G protein coupled receptors, the first of which was described, ALX-FPR2, is depicted here. And interestingly, the ALX receptor can bind both lipid and protein ligands. So SAA and LXA4 each serve as an agonist for the ALX receptor, and each can antagonize the signaling of the other through allosteric inhibition, promoting opposite intracellular effects. SAA signals for epithelial cell release of pro-inflammatory cytokines and neutrophil activation, chemotaxis, and survival, while LXA4 signaling through ALX inhibits neutrophil activation, adhesion, and migration, and impairs pro-inflammatory cytokine release. So coming back to our study here in SARP-3, where we found that LXA4 and SAA levels were inversely correlated with one another with opposite relationships to airway neutrophilia and a protective effect of LXA4 for lung function in asthma. So because of their inverse correlation with one another, we next examined relationships between high and low levels of these two ALX ligands and found an interesting dichotomy. About a third of our cohort had high LXA levels and low SAA levels here in the tan. Similarly, about a third of the cohort had low LXA4 levels and high SAA levels here in the purple. And when we compared these two opposite populations in asthma subjects, we found an important difference in asthma measures. SAA high, LXA4 low subjects in purple had an increased percentage of BAL neutrophils and reported more asthma symptoms. Further, they had lower lung function than the cohort with low SAA and high LXA4 in tan. So these data suggest that SAA high, LXA4 low asthma defines an endotype characterized by more asthma symptoms, lower lung function, and increased airway neutrophils. There have been a number of SPM receptors that have been discovered in the past decade, and these receptors are expressed on numerous cell types. Focusing on ALX, we and others have shown that circulating and airway NK cells express this receptor and are therefore equipped to respond to the SPM LXA4. So now I'd like to share with you some of our in vitro studies examining the impact of LXA4 versus steroids on NK cell function. So coming back to my schema here, we focused on NK cell cytotoxic effector function. And one way to study this in vitro is to use an NK cell susceptible myeloid target cell line and examine the ability of isolated NK cells to induce target cell apoptosis using flow cytometry. So we used this system to evaluate NK cell cytotoxic effector function in a subset of SARP-3 asthma subjects. We isolated circulating NK cells and co-cultured them with a susceptible target cell line and evaluated their ability to induce apoptosis of the target cells using flow cytometry staining for 7-AAD and annexin-5. And in these experimental conditions, ex vivo, NK cells from healthy donors, shown here, appropriately killed target cells. NK cells from asthma patients, however, had impaired cytotoxicity, leading to significantly less target cell apoptosis than healthy subjects. Well, because steroids are the mainstay of treatment for asthma and all of these subjects were treated with steroids, led us to hypothesize that steroid exposure suppressed NK cell effector function. So to investigate this in the next series of experiments, we did a head-to-head comparison of the effects of the steroid dexamethasone and the specialized pro-resolving mediator LXA4 on NK cell cytotoxic effector function. NK cells were isolated from healthy subjects and exposed to either vehicle control in gray, dexamethasone in blue, or LXA4 in red for 48 hours prior to co-culture with K562 myeloid tumor cell targets for 4 hours. We evaluated target cell apoptosis by flow cytometry staining as before. And in these conditions, in vehicle control exposed NK cells, there was an appropriate induction of apoptosis of about 50% of target cells at the 4-hour time point. Exposure to dexamethasone dramatically decreased NK cell mediated cytotoxicity, an about approximate 65% reduction relative to vehicle control. In sharp contrast, lipoxin A4 enhanced NK cell cytotoxicity, resulting in augmented cytotoxicity above control conditions. So given these differential effects of DEX and LXA4 on NK cell effector function, we next asked what intracellular mechanisms may be involved. When an NK cell, depicted here in tan, encounters an abnormal cell, depicted here in green, it forms an immune synapse, and F-actin accumulates there. Lytic granules containing perforin, here the red circles, traffic along microtubules towards the microtubule organizing center, or MTOC. This complex is then polarized towards the target cell immune synapse, where perforin forms pores in the target cell membrane through which granzymes enter and induce target cell apoptosis while avoiding bystander tissue damage. We hypothesized that this intricate process of lytic granule trafficking was disrupted by steroids and enhanced by SPMs. So we turned to confocal microscopy to study this at the microscopic level. Here, NK cells were exposed as before to either vehicle control in gray, dexamethasone in blue, or lipoxin A4 in red. And we studied intracellular F-actin here in red, perforin to mark the lytic granules in green, and alpha-tubulin in blue to denote the microtubule organizing center using confocal microscopy, with attention really at the immune synapse here at the interface between the NK cell and the target cell. And what you can note in these representative images and quantitated here is that F-actin density at the immune synapse in DEX-exposed NK cells was less than 50% that of vehicle control. In contrast, accumulation of F-actin at the target cell synapse was preserved in LXA4 exposed NK cells. We measured the mTOC to synapse distance here in microns on the x-axis and found this was significantly further in DEX-exposed NK cells with a median close to 4 microns relative to control cells with a median of 2 microns. And in fact, this distance was even shorter in LXA4 exposed NK cells at 1.4 microns. In this study, we went on to identify the limb kinase family of actin cytoskeleton regulators that were downregulated by dexamethasone and increased by lipoxin A4. And we found that inhibiting limb kinase with a small molecule inhibitor recapitulated this disruption of F-actin accumulation and mTOC polarization with impaired cytotoxicity that we'd observed with steroids. So here in this series of in vitro experiments, we demonstrated that the SPM lipoxin A4 promoted NK cell-induced target cell apoptosis, while steroids blocked this process. This may have relevance to pathobiology in asthma, where steroid exposure may be having unintended effects to impair granulocyte apoptosis and impede downstream processes of inflammation resolution pathways, perpetuating chronic inflammation. I want to touch on one more cellular pathway for non-T2 inflammation in asthma, the mast cell. Tanya Laidlaw and Joshua Boyce here at the Brigham, working in aspirin-exacerbated respiratory disease, have uncovered a number of biochemical and cell-cell interaction mechanisms by which mast cells contribute to lung inflammation. Mast cells can release preformed granules and inflammatory mediators, and crosstalk between mast cells and airway smooth muscle cells can contribute to airway hyperresponsiveness. Epithelial cell alarmins, IL-33 and TSLP, activated by mast cell tryptase, may drive some of these inflammatory pathobiologic processes through downstream mast cell activity. The UBioPred group in the UK found that mast cells from asthma endobronchial biopsies stimulated ex vivo with IL-33 evoked an immune signature that was strongly associated with severe neutrophilic asthma. Further evidence of a role for mast cells in severe asthma was shown in this study led by Elliot Israel and Katie Cahill. Here, KIT inhibition with imatinib in severe asthma reduced airway methacholine reactivity and serum tryptase levels, as well as airway mast cell counts. And notably, in exploratory analyses, they found that increases in lung function, so FEV1 after imatinib treatment, were strongly associated with baseline BAL neutrophil counts. So together, these studies demonstrate a role for mast cells not only in type 2 high asthma, but also type 2 low asthma. Finally, two recent studies led by Michael Peters and John Fahey at UCSF have identified a role for IL-6 and metabolic dysfunction in asthma severity. 26% of the SART-3 cohort had elevated plasma IL-6 levels, and IL-6 was correlated with blood neutrophilia. IL-6 high patients had higher BMI and a higher prevalence of both hypertension and diabetes in this study. High IL-6 patients here in the light pink bars had worse lung function and more frequent exacerbations than patients who had low IL-6 levels. In a recent follow-on study, degree of insulin resistance was evaluated using HOMA-IR measures, and patients with severe insulin resistance here in the orange had lower lung function and a more accelerated decline in lung function over time than asthma patients with moderate or no insulin resistance. So these studies demonstrate an outside-in mechanism of non-type 2 systemic inflammation associated with asthma severity. So what is on the horizon for targeted treatment of type 2 low asthma? Targeting the IL-6 systemic inflammation pathway I just reviewed, the PRECISE network is currently enrolling asthma patients with high plasma IL-6 in a trial of the anti-IL-6 monoclonal clazakizumab. targeting the mast cell axis. Another arm of PRECISE includes evaluating the impact of imatinib specifically for patients with T2 low asthma, those with blood eosinophils less than 300. Tezepelumab targeting TSLP is available for clinical use and has been shown to be effective at reducing exacerbations in severe asthma in both patients with type 2 high and type 2 low disease, including patients with lower blood eosinophil and FeNO levels. Another strategy getting at the epithelial cell, IL-33 alarmin, mast cell ST2 axis is a phase 2 trial of astegolimab, a neutralizing antibody against ST2, which reduced asthma exacerbations, including in those with blood eosinophils less than 300. So these therapies on the horizon target some, but not all, of the non-T2 inflammatory pathways that I reviewed today, identifying that continued need for discovery in this important clinical space is a priority. So what I've reviewed with you today is evidence for inflammation pathways that are operative in type 2 low asthma, including neutrophilic inflammation and netosis, adaptive Th1 and Th17 pathways, natural killer cell dysfunction, and effective inflammation resolution pathways, as well as mast cell biology and IL-6 systemic pathways that provoke non-type 2 inflammation in asthma. Non-type 2 biomarkers and new targeted therapies are urgently needed for steroid unresponsive asthma. So we'll continue to need to watch this space closely over the near term to update what we know and continue with discovery-based science to better understand what we don't yet know. And with that, I would like to acknowledge an incredible collection of people who are essential mentors and collaborators. In particular, Bruce Levy for his long-term mentorship, and all our colleagues in the laboratory for their contributions to this work. Elliot Israel and Wanda Fepitanicu locally, and the entire SARP team across the country, and in particular the patients who participated in SARP for so many years. My departmental leadership at Boston Children's for support and mentorship, my federal and internal funding sources, and you for your attention. I'd be delighted to take some questions.
That was a beautiful review, Melody, and what a beautiful body of work. And thank you so much for sharing the ongoing discoveries that you're making with this broader audience. Let me start with one or two questions, if I can. So in terms of the non-T2 pathways, one of the problems that we have is that, and I think you alluded to this, is that we're describing this as what it isn't rather than what it is. And I wonder if you kind of had to pick your most favorite or the pathways you think are most likely to yield results in a broader population of non-T2 patients, which ones would you focus on?
Well, you didn't start with any easy questions, did you, Elliot? Yeah, your point is a good one. What we're lacking really in this group of patients are specific biomarkers, and these are not easy to measure. I think counting the number of eosinophils, measuring FeNO, measuring IgE. We've gotten familiar with those. Other things are more complicated. We can now measure IL-6, but it's challenging to do so. We need a very sensitive assay, and there's differences between labs. So we need some consistent tools to be able to measure these things adequately. I think the other thing that we struggle with as a population, a group of physicians and scientists, is what measuring things in the blood means for what's happening in the airway. And so I think we need to sort of make correlations between biomarkers that we identify perhaps in the airway that we can also track more easily in the blood. And I think this is a time to stay broad and not narrow, because I think we don't know what we don't know at this stage. And so I highlighted 7 pathways today. And if I had to pick one, I don't know where I would start. I think there's more data in the neutrophil sort of arena, and less we're familiar, less the others we're less familiar with. So I would say, rather than picking a pathway, I would continue with discovery and stay broad.
Okay, great. And there's a question from Nora Barrett to thank you for a great talk, and mentioned that Brian Kim had a nice paper in Science Translational Medicine describing NK cell deficiency in atopic dermatitis and improvement in function with supplemental IL-15. Are the defects that you described here, do you think they're amenable to that or other immunotherapy?
Thanks, Dr. Barrett. And I'm familiar with this study, and it is a very interesting piece of clinical translational information. If you take NK cells just ex vivo and you stimulate them with IL-15 or IL-12 or IL-18, they will kill better. So cytotoxic effector function becomes quite strong. I think it's that tricky balance of how do you stimulate enough so that you have good function versus too much function. And so I think that is a fine balance. There are a number of groups thinking about clinical trials involving NK cells, taking them out, engineering them in vitro, either with stimulation with IL-15 or bikes and trikes and various sort of more specific stimuli. And I think this is in the early stage of discovery, but certainly of interest here. We're particularly interested in the concept of SPM. So could we, for instance, engineer NK cells in vitro with a combination of either cytokines, as you mentioned, or pro-resolving mediators that really stimulate the more beneficial pathways for NK cell activity? So watch this space is, I think, my takeaway there.
Okay, thanks. And Chris Fante asked the question about how we can identify specifically type 2 low patients, especially in steroid-treated asthma patients, where presumably a lot of the T2 markers are being suppressed by steroids.
Yeah, thanks, Chris. And I think this again highlights what we're looking for is the absence of what we know. And what we don't know, I think, is still as yet to be discovered. I think studies like PRECISE and STARP and UBioPred have the sort of fortune of having large groups of asthma patients. And so, targeting and comparing soluble mediators in blood and airway in different subgroups of patients is now feasible when we've got several hundred or even thousands of patients across the world that we can study, and sort of parsing out these different phenotypes and then comparing, as you say, what does, for instance, the IL-6 levels look like in patients on steroids, or this biologic or that biologic, or NK cell function. I think the other sort of piece of this is that, I'm showing you, we're mainly looking at a snapshot in time, but the longitudinal change of these biomarkers over time is important to understand. So patients are not always with evidence of type 2 inflammation consistently. There are some patients who are always high. There are some patients that are sometimes high and sometimes low. And there are patients who are T2 low persistently. And we hope to uncover that. That's one of the main goals of SARP-4 now, is to understand these biomarkers longitudinally and how they relate to clinical symptoms over time.
Thank you. And another question. So you mentioned anti-TSLP therapy, and you kind of alluded to the fact that that it works in what appear to be T2 low patients. Do you think that this is actually that this is actually due to its function working in T2 low mechanisms, or do you think that these are really patients who are formed first of T2 high and where their biomarkers are being suppressed?
Well, that's a good question. And I think sort of, again, highlights what we don't know. I have less familiarity with the tezepelumab patients. I'd be interested in others' thoughts. Have they uncovered, any sort of relationship to maybe longitudinal type 2 markers over time? I don't know, Elliot, if you have thoughts on that.
I think we're beginning to wonder whether these are actually type 2 biomarker lowish patients, but really who have kind of biomarkers suppressed but continuing ongoing T2 inflammation. So more to come in that. Thanks for your thoughts on that. And Josh Boyce asked the question, given the impact of macrolide antibiotics on both bacteria positive and bacteria negative patients, do you think that bacterial colonization in severe asthma reflects an epiphenomenon of steroid use or mucosal damage, or a pathogenic driver of inflammation?
Yeah, I think it's a good question. I'm not as familiar with the macrolide antibiotic field, but we use it at least in part for anti-inflammatory effects. But what does that really mean? I think is yet to be determined. I think that was, I didn't highlight it when I reviewed the AMAZES trial, but that was there. So in the subgroup analysis, they found that azithromycin was positive for both, was beneficial for both patients with bacteria positive and bacteria negative disease. So it suggests that the azithromycin is probably not just working on bacterial colonization, but probably has downstream immune effects that we have yet to understand more fully.
Thanks. And then another question was, how close are we to treatment of severe asthma with a lipoxin A4 analog?
Great question, Chris. And this is a space of active discovery. Lipoxin A4, as I mentioned, is one of now 30 or so mediators that we have identified and study. And there are, in fact, a handful that are in clinical trials currently. So there was a recent trial in infants with eczema, so atopic dermatitis, looking at a topical lipoxin A4. This was a double-blind, placebo-controlled trial, and they found that for infantile eczema, topical LXA4 was as effective as steroids. Of course, the sort of parent polyunsaturated omega-3 fatty acids was shown to reduce infantile wheeze and asthma in a New England Journal paper in 2016. And there are other SPMs, resolvins, that are in clinical trials now for dry eye, periodontal disease, and others. So I think on the horizon is how I would describe that, Chris.
Right. Okay. All right. Melody, I wanted to thank you again for a really wonderful talk, and appreciate your taking the time to share this with us. And we look forward to hearing more exciting discoveries coming from your work. And we invite you to join us in a few months for our next asthma grand rounds. Have a good weekend, everybody. And again, Happy New Year to all. Bye-bye.
Thank you.